Hello everyone. Welcome back to the series of lectures in pulmonology. Today we'll be discussing a very important topic, which is acute respiratory distress syndrome and respiratory failure. So let's begin. So what is the definition of ARDS? So what exactly is acute respiratory distress syndrome? So ARDS is basically a clinical syndrome which comprises of severe dyspnea of rapid onset hypoxemia and diffuse pulmonary infiltrates resulting in respiratory failure. So ARDS is basically a disorder which is characterized by accumulation of fluid and exudates within the lung, and this is of acute onset, and it usually happens when the insult is less than 7 days. So within a week they deteriorate rapidly and there is severe dyspnea and hypoxemia, and it is characterized by diffuse pulmonary infiltrates leading to respiratory failure. Okay, so the other name for ARDS is non-cardiogenic pulmonary edema. Okay, so this is also called as non-cardiogenic pulmonary edema. Okay. So why is it non-cardiogenic? Because if there is an underlying cardiogenic cause like heart failure which results in fluid accumulation in the lungs, then this is not an ARDS. Okay, so this is also called as non-cardiogenic pulmonary edema. So let us look at the disorders which are associated with ARDS, right? So this ARDS can happen due to direct lung injury or indirect lung injury. Indirect lung injury means because of certain medical or surgical conditions which predispose to these kind of lung injuries or ARDS is the mechanism behind this. So this accounts for approximately 80% of the cases of ARDS, and direct lung injury secondary to maybe a pneumonia accounts for up to 40% of the cases with ARDS. There can be an overlap as well, but this is how you broadly classify. So this is how you broadly classify it. Okay. So what are the causes which can directly affect the lung? This includes pneumonia, aspiration pneumonia, like so for patients with altered sensorium. So for patients with altered sensorium, you can have aspiration of gastric contents. Then injuries, near drowning experiences or toxic inhalational injuries, all of these cause a direct injury to the lung parenchyma. Then indirect causes includes medical and surgical conditions, severe sepsis, trauma, and trauma associated with bone fractures, flail chest, head trauma, burns, transfusion related injuries. We have heard of TRALI, right? Transfusion related acute lung injury, right? So that is a form of ARDS. This is TRALI. Then pancreatitis, post-surgical procedures including cardiopulmonary bypass. Okay, so this is about the various etiologies for ARDS. So let us understand that ARDS is a non-cardiogenic pulmonary edema. So what do you have here? You have a clinical syndrome characterized by rapid onset. Okay, within 1 week of the insult, you can have hypoxemia and acute respiratory failure, and the characteristic feature is that there are diffuse pulmonary infiltrates. Now, let us understand the clinical course. So throughout this ARDS, you have 3 phases. The first phase that you have to know is called as the exudative phase. The exudative phase occurs within 7 days of the damage. Okay, within 7 days of your injury, the phase that you have, the ARDS that is developing, is your exudative phase. So let us understand what happens during the exudative phase. So this is a diagrammatic representation of the alveolus. Okay, this is the alveolus, and we know that each of the alveoli are lined by a surfactant. Okay, and this is your type 2 pneumocyte. Okay, so whenever there is a damage to the alveoli, what happens? There is recruitment of the polymorphonuclear lymphocytes, right? So there is going to be inflammation. So first is there will be inflammation. There will be recruitment of the polymorphonuclear lymphocytes that you can see here, PMN, or your neutrophils basically. There are a lot of neutrophils and macrophages which infiltrate into the alveoli. Apart from this, what is going to get damaged? There is going to be damage of type 1 pneumocytes. Okay, there is going to be damage of type 1 pneumocytes. The type 1 pneumocytes are basically those which are involved in the formation of the epithelium which lines the alveoli. So if the type 1 pneumocytes are damaged, the epithelium is going to get denuded. The epithelium gets broken down. Okay? Right? Apart from that, what happens? There is less production of surfactant. There is no surfactant. Right? So there is loss of surfactant. There is loss of surfactant. There is inflammation, there is damage to the epithelial cells of the alveoli. Apart from that, there is loss of surfactant and there is accumulation of this inflammatory fluid within the lungs. Okay, so there is accumulation of fluid within the lungs. Alright. Apart from this, you can also have some amount of vascular compromise which is depicted here. Now, over the course of time, what happens is that this inflammation can also result in fibrosis. So, these inflammatory mediators which are produced include TNF-alpha, interleukin-6, interleukin-8, and all of these over the course of time can also promote fibrogenesis. Okay? So, this is what happens in your pathogenesis of ARDS. Right? Apart from this, during your proliferation phase and during your phase of repair, what happens is that there can be increased production of type 2 cells. There can be increased production of type 2 pneumocytes. There is damage of the type 1 cells and there is damage to the epithelium. The type 2 pneumocytes then proliferate and they try to get converted into the epithelial cells and they help in the repair. So, type 2 pneumocytes can get proliferated in the later stages of ARDS to help in the repair. Okay, fine. So, this is your pathogenesis. So, during the first phase, which is your exudative phase, which happens during the first 7 days of ARDS, what are the repercussions? The repercussions are, there is going to be a decreased lung compliance. Yes, there is going to be a decreased lung compliance because of loss of surfactant. So, the alveoli are basically in your distended state. When the surfactant is present, when there is loss of surfactant, all of the alveoli can also undergo atelectasis. Apart from this, because of damage to the vasculature, you can have intrapulmonary shunting. And finally, this results in hypoxia and hypercapnia. Hypercapnia means PaO₂ retention. There is more PaO₂ in the body. So, can you see this X-ray? What are you seeing here? You are seeing here diffuse pulmonary infiltrates which are bilateral diffuse pulmonary infiltrates. Okay, fine. And you do not see much of pleural effusions because this is a non-cardiogenic pulmonary edema. Okay, fine. Then 7 to 21 days we go into the next phase which is called as the proliferative phase of ARDS. In the first week we have the exudative phase, then in the second week we have the proliferative phase. So, in the proliferative phase, what happens is that this lasts from your second to third week. So, there is lung repair. The lung attempts to repair. So, how is this brought about? The type 2 pneumocytes. The type 2 pneumocytes are stimulated. Type 2 pneumocytes are stimulated. Now, once the type 2 pneumocytes are stimulated, they try and differentiate and try to re-epithelialize the alveoli and try to increase the surfactant production. Then finally, we move on to the fibrotic phase. So, many times via the proliferative phase during lung repair, people can improve. But there can be many patients, especially in the post-COVID era that we have seen, they go into the fibrotic phase after 3 weeks of continuous inflammation. Okay, so in the fibrotic phase, what happens is, the acini get destroyed. The acini get destroyed. Normal acinus becomes like this, right? Over the course of time, they become more emphysematous. They tend to retain the gases. There is fibrosis, and over a period of time, chronically, as the pneumonia becomes more and more organized, as the exudates become more and more organized, and then they undergo fibrosis, over the course of time, the entire lung gets damaged. And whenever the entire lung gets damaged, the afterload on the RV is increased and they can develop pulmonary hypertension. Okay, they behave very similar to your interstitial lung diseases, which can also develop pulmonary hypertension because of fibrosis. Okay, so this is about the 3 phases of ARDS. Now let us go on to the diagnostic criteria, and the diagnostic criteria that we use for ARDS is your very famous Berlin's criteria. So what does the Berlin's criteria say? Berlin's criteria has certain components onto it. So first let us look at the onset. Onset is acute in onset within 1 week of a clinical insult or new or worsening respiratory symptoms. So this is within 1 week. Chest radiograph findings, bilateral opacity is consistent with pulmonary edema, but it is not fully explained by your cardiogenic causes, right? So there are no effusions, there are no lobar or lung collapses, or no evidence of any other cause like nodules. Then, absence of left atrial hypertension. Left atrial hypertension means what? Left atrial enlargement means what? It means that there is some underlying cardiac problem. That also has to be ruled out. So, if you have to call a patient as ARDS, there should be no underlying cardiogenic cause for pulmonary edema. Okay? So, the hydrostatic edema is not the primary cause of respiratory failure. Right? So, we do an echo, you rule out the cardiac cause of pulmonary edema, and then only you call it your ARDS. The most important of the criteria, which is part of Berlin's criteria, is your severity, which is denoted by oxygenation capacity. So, it is classified as mild, moderate and severe ARDS. Okay, so we classify the ARDS as mild, moderate and severe ARDS. And this is given by the ratio, which is your PaO₂ by FiO₂ ratio. PaO₂ is your basically your oxygen saturation or your oxygen concentration. FiO₂ is the percentage of oxygen that you are delivering during your oxygenation process. For example, if the patient is on mechanical ventilator, how much oxygen you are delivering to him? Is it 50% oxygen? Is it 100% oxygen? That is your FiO₂. So, PaO₂ by FiO₂ ratio is basically used to grade the severity of ARDS. Okay. So, PaO₂ by FiO₂ ratio less than 300 is mild. Okay. Then 100 to 200 is moderate ARDS and less than 100 is severe ARDS. Okay. So, this is your Berlin criteria and you remember these values for your PF ratios. Now, there has been a global update in the management of ARDS and there has been modifications to the Berlin's criteria. Okay. So, especially during the COVID times, what we noticed is that even patients who are not on ventilators can have ARDS. That is true, right? But the Berlin's criteria defines ARDS only based on your PF ratios if the patient is on a mechanical ventilator. Now, how do you define your non-intubated ARDS? So, in your non-intubated ARDS, what we look at is your SpO2 to FiO2 ratio. Okay. So, non-intubated ARDS means what? They can be on a face mask, they can be on a high flow nasal cannula, they can be on a non-invasive method of mechanical ventilation like your BiPAP. Okay. So, here you can use an SpO2 by FiO2 ratio. Okay. So, if the patient is on an HFNC, a high flow nasal oxygen with a flow less than 30 liters per minute, then we take an SF ratio less than 315 as your ARDS definition. Or if the patient is on an NIV or non-invasive ventilator or a CPAP mode, then the positive end expiratory pressure, which is your PEEP, should be at least 5 centimeters of water, and then we take the SF ratio and not the PaO2 FiO2 ratio. Intubated ARDS, the definitions are almost the same. Okay. Then, in your resource limited settings, if the patient is not on a positive end expiratory pressure nor a minimum flow rate of oxygen is required, then SF ratio less than 315 is directly considered to be ARDS even if the patient is on a face mask. Okay. So, this is what it means. So, the definitions have slightly got modified for non-intubated versus intubated ARDS, and we will see this with the examples as below. So, a 68-year-old male with abdominal sepsis, septic shock and acute hypoxemic respiratory failure. Okay. So, he is mechanically ventilated. He is mechanically ventilated and you have the PF ratios. The PF ratios is 150. Okay. So, what type of ARDS this is? This is an intubated ARDS. PF ratio 150 means between 100 to 200 moderate ARDS. So, this is a typical patient according to the Berlin's criteria. Okay. Now, let us look at the other patient. 50-year-old female with history of breast cancer, COVID-19, worsening shortness of breath for the past 6 days. Okay. And what is she on? Can you see this device? This device is a high flow nasal cannula which can give flows up to 60 liters per minute. This is the highest amount of non-invasive ventilation that you can give using a HFNC. Can you see the X-ray? You are seeing diffuse pulmonary infiltrates, right? So, In this type of ARDS, this is a non-intubated ARDS. So you see the SF ratio, SpO2 FiO2 ratio. SpO2 91, FiO2 0.8, SF ratio is around 14. So non-intubated ARDS is a new category. Right? Now let us see this. 39-year-old female with sepsis, gram-negative bacteremia, and she is in an under-resourced hospital. Okay, radiography is not there, blood gases is not there, mechanical ventilation is also not there, and you're just giving a face mask. So can you diagnose ARDS in this patient? Right? So the patient is on supplemental oxygen by face mask at 15 liters per minute. Can you diagnose ARDS? Yes. So you can use your SF ratios, SpO2 85%, FiO2 0.6, so SF ratio 142. So this is again your ARDS, right? So ARDS in resource limited settings is also a new definition, right? That is what we have looked at, and this is how you approach your diagnosis of ARDS. Now let us move on to the management of ARDS, right? So what are the general principles in the management of ARDS? So first principle is that we decrease what we call as volute trauma. Volute trauma basically means that whenever the patient is on a mechanical ventilator, we know that we are giving a certain amount of gas at a certain pressure at a certain velocity. In ARDS, there are certain parts of the lungs which are well ventilated, there are certain parts of the lung which are not well ventilated. So there can be normal areas, there can be abnormal areas which are affected by the ARDS. Some of the areas are not affected. So whenever we give the ventilator at a specific pressure, at higher pressures or higher velocity, what happens in the normal areas of the lung? In the normal areas of the lungs, you can have over-distension. In the normal areas of the lung, you can have over-distension of the alveoli resulting in rupture. Okay, so this is what we call as volute trauma. So if you give your mechanical ventilation tidal volumes at higher volumes, let us say your traditional tidal volume which is used in your mechanical ventilator is 12 ml per kg. So at this higher volumes, we found that the normal areas of the lung, the alveoli can undergo over-distension and rupture in the normal areas. Okay, so that is the reason why you basically resort to what we call as the low tidal volume mechanical ventilation in ARDS, where the tidal volume is restricted to about 6 ml per kg. So this is to ensure that we have reduced your volute trauma. Now, there is something called as atelectotrauma as well. So what is the meaning of atelectotrauma? So in ARDS, there is loss of surfactant. Loss of surfactant results in decreased compliance. It results in decreased compliance, and hence all of the alveoli can collapse or they can undergo atelectasis. Atelectasis basically means collapse, right? So all of the alveoli undergo atelectasis or they undergo collapse because of loss of surfactant, right? So to prevent this, what should you do? You should give a positive end expiratory pressure. That means what? At the end of expiration, you give some amount of positive pressure so that the lung does not collapse and it remains infiltrated, because when you expire, the pressure inside the alveoli becomes very, very low, and as a result of which they begin to collapse. So you give them positive end expiratory pressure so that they don't collapse. And this is how you manage your atelectotrauma. So you prevent volute trauma by giving a low tidal volume mechanical ventilation. You prevent the atelectotrauma by ensuring that you give a positive end expiratory pressure at approximately 5 cm of water. Okay. Then other maneuvers which can be done include proning. It has been found that proning the patient, okay, keeping them prone for about 16 hours in the entire 24-hour period, in patients who is requiring more than 60% FiO2, the mortality benefits have found to be more. Okay, so proning basically ensures that the bases of the lungs open up, and these patients remain prone for about 16 hours out of one particular day. And in those patients who are requiring more than 60% FiO2, proning helps in improving the mortality. What are the conditions where proning is contraindicated? So proning is contraindicated in conditions where there is a raised intracranial pressure, in C-spine injuries, post-surgical patients, right? Post-surgical patients, especially abdominal surgeries, or in patients with hemoptysis, because if they have another episode of hemoptysis, they can aspirate that as well. So proning is contraindicated in these patients, right? Apart from this, what we do something called as recruitment maneuvers. Okay, so what is the meaning of recruitment maneuver? Please cut the last word. So what is the meaning of recruitment maneuvers? So recruitment basically means that there are certain alveoli which are not participating in respiration. So these alveoli are also recruited so that you improve your oxygenation, and that is what we call as recruitment maneuver. So in this, what do? We apply high level continuous positive airway pressure. Okay, so you apply high level continuous positive airway pressure. So what happens? The alveoli get distended. So if we have alveoli which are not participating in the respiration, they also get distended and they can start participating in the respiration, right? So with the goal of recruiting a non-gas exchanging portion. Okay, so that is your recruitment maneuvers. Understood? So application of high level positive pressure with the goal of recruiting a non-gas exchanging portion of the lung is called as recruitment maneuver. But whenever you're doing a recruitment maneuver, you do it for a very short amount of time because of the risk of volute trauma. Fine? Then let us look at the other aspects in the management of ARDS. So fluid management, right? So in fluid management, what do you consider? You always have to do an echocardiography to rule out cardiogenic causes of pulmonary edema. Apart from that, you can also look at the IVC or the inferior vena cava compressibility to see the volume status of the patient, because in patients who are in volume overload, this can in turn cause worsening accumulation of fluid in the lungs and worsen the ARDS, and hence always try to maintain a low left atrial pressure. Fluid restriction is actually told in patients for ARDS because it can worsen the pulmonary edema. And neuromuscular blockade, especially with cis-atracurium, has been found to help the patients because early neuromuscular blockade helps in decreasing the respiratory effort. The respiratory muscles also get paralyzed and it decreases the respiratory effort and it improves the mortality. So early neuromuscular blockade is suggested in patients with ARDS. When it comes to glucocorticoids help in reducing the inflammation, but there is been no role of glucocorticoids actively, or regular use of glucocorticoids has not been advised in the management of ARDS. So what you have to remember is your low tidal volume mechanical ventilation, then the presence of a positive end expiratory pressure, then you can use proning, you can use recruitment maneuvers, right? Then you will have to do a fluid restriction, and glucocorticoids do not have a regular management of ARDS. Now let us understand the flow chart. Okay, so once a patient with ARDS presents, he has to be mechanically ventilated. Then you initiate a volume or pressure limited ventilation. Why? We have already looked at. You do not want to cause volute trauma. You do not want to cause barotrauma, which is pressure related trauma to the lungs. So tidal volume less than 6 ml per kg body weight. Then plateau pressure less than 30. Okay, plateau pressure means amount of pressure that you are giving in the mechanical ventilator should be less than 30, and you target a respiratory rate of less than 35. You oxygenate well. Okay, you keep the saturation less about 88 to 95% and the FiO₂ less than 60%. That should be your target. So you keep your FiO₂ less than 60% in the machine and you target a saturation of the patient between 88 to 95%. Minimize the acidosis. You do not want them to go into respiratory acidosis. Keep the pH more than 7.3 and respiratory rate less than 35. And you ensure a proper diuresis, ensure that they do not become in volume overload, and such that you avoid hypoperfusion, right? So if you don't want patient to go into volume overload, you might end up giving them diuretics, right? When you give them diuretics, you do not want the patient to go into shock, so be very careful about that. Ensure that the mean arterial pressure is more than 65 milliliters of mercury, and you avoid hypoperfusion, avoid hypotension. Okay, so this is the most important flow chart with respect to ARDS. So with this, we have understood the management of acute respiratory distress syndrome. Thank you.